Hello and welcome back to the ASCO Journal of Oncology Practice podcast. This is Dr. Bob Miller of the JOP editorial board and medical oncologist at Johns Hopkins. On February 22nd, ASCO released an update of a clinical practice guideline entitled Recommendations on the Role of Bone-Modifying Agents in Metastatic Breast Cancer. ASCO had initially published an evidence-based clinical practice guideline for the use of bisphosphonates in breast cancer in 2000, with an update in 2003. Summaries of this new 2011 guideline appeared in JCO and in the JOP in March. Also in the March JOP, we published a commentary about the role of bone-modifying agents, or BMAs, by Dr. Gabriel Hortobagyi. I'm pleased to have Dr. Hortobagyi as my guest tonight for this podcast. He is the director of the Breast Cancer Research Program at the University of Texas MD Anderson Cancer Center and chairman of Breast Medical Oncology. Dr. Hortobagyi developed successful curative treatments for locally advanced breast cancer and led the clinical development of numerous new cytotoxic and hormonal agents over the past 30 years. And of course, he has served as president of ASCO in 2006-2007. Welcome, Gabe.
Thank you, Bob, for having me.
I want to ask you first about the process that ASCO goes through for this guideline and all of their guidelines. They start with a comprehensive literature review and follow a pre-established protocol for identifying studies that support an evidence-based guideline. Can you tell us how is this different from the process that NCCN and others use, and why should this matter to clinicians who are really just looking for guidance in managing patients?
Well, this is an important point and an important difference between the ASCO guidelines in general and most other guidelines promulgated by other societies or groups. The ASCO Health Services Committee undertakes a very extensive and comprehensive review of the literature based on a pre-established protocol that defines the time period during which published information is obtained, defines the type of studies and the characteristics of the studies that are to be included in the analysis, and then defines the process by which the guidelines are going to be developed. And utilizing the classical levels of evidence, ASCO guideline committee members then select the evidence, qualify the evidence, and then promulgate the guidelines that we all use. Now, this is a time-consuming process. It often takes many months to collect and clean the information. And then the committee members spend a considerable amount of time deciding what should be included in the guidelines and how the guidelines should express the level of evidence. This is in contradistinction with NCCN and many other professional societies where guidelines do incorporate evidence, but they are based largely on the consensus of a group of experts. Now, because of the character and the type of process that ASCO utilizes for developing guidelines, it tends to be more conservative than other guidelines that come out from other societies or groups. But because of the very exhaustive review and the careful consideration of the characteristics, I think it is the most accurate and best use of evidence.
I see. Tell me a little bit about this guideline. So this was an update of a 2003 bisphosphonate guideline. Why did the guideline committee choose to focus solely on patients with metastatic breast cancer? Did they consider dealing with the issue of bisphosphonates in the adjuvant setting?
So there were a couple of important reasons to focus on metastatic breast cancer. First of all, multiple myeloma and metastatic breast cancer have been the major developmental areas for all of the bone-modifying agents. But breast cancer is by far a much larger segment of the cancer population. And because of that, and because recent developments have occurred predominantly in the breast cancer group, the guideline committee focused on this area. Now, there are two important updates that have occurred since 2003 in bone-modifying agents. One is that we have developed much more extensive and more reliable information and evidence on the intermediate and long-term toxicity or safety profile of bisphosphonates in general, and especially the intravenous third-generation bisphosphonates. And second, that there is now a new agent, a rank ligand inhibitor, denosumab, that has passed the muster of prospective phase 3 trials with the demonstration that it has some therapeutic superiority compared to the third-generation bisphosphonates. So the committee felt that these two changes in the existing evidence warranted an update of this guideline. And the changes occurred mostly in metastatic breast cancer, so that's where the guideline modifications occurred.
I see. So you mentioned the new agent. So denosumab was FDA approved within the last 6 months. There was a study that was published in the JCO in December 2010. I think the first author was Alison Stopek, and if I remember correctly, it seemed to show that denosumab was actually superior to zoledronic acid in the time to the first and the subsequent on-study skeletal-related event. The hazard ratio was 0.77. Why didn't the guideline panel come out with a stronger recommendation for denosumab over bisphosphonates based on that trial, or perhaps that was not sufficient evidence to meet their criteria?
Well, the Stopek paper is an important paper, and it's a well-conducted phase 3 trial. It has a relatively short follow-up, and it is the only trial in breast cancer that is a controlled trial. That is in contradistinction with the bisphosphonate trials, where we have over 20 years of experience with pamidronate and at least 10 years of experience with zoledronic acid and ivandronate and some of the other third-generation bisphosphonates. So there is a much greater level of confidence in both what we know and what we don't know with bisphosphonates. The second aspect of it is that in the FDA review of denosumab, while there was clear superiority of denosumab over zoledronic acid, there were some lingering questions about the safety profile, especially as related to uncommon toxicities. The FDA pointed out that there was an excess of infectious complications with denosumab in some of the experience to date. And of course, there is also some reports of osteonecrosis of the jaw, similar in proportion to that observed with zoledronic acid and other bisphosphonates, although the experience with denosumab being much smaller, the degree of precision with which one can define the frequency of that event was less confident. So because of those two differences between the two classes of drugs, the committee elected to be less than compelling in its recommendation, recognizing that the evidence does point to the superiority of denosumab, but giving some opportunity for additional experience to accumulate, especially in what relates to the safety profile.
I think when I first read the guideline, I was really interested in seeing if the question that so many clinicians face, which is about the timing and chronic dosing, was going to be addressed. Certainly a common clinical question that comes up is you have a breast cancer patient who has been stable, has stable bone disease, who's been on an AI, has been on zoledronic acid for a year or two. What do you do? Do you reduce the frequency of administration? Do you stop? That wasn't covered by the guideline. Can you comment on that, whether there's some thought that this may be covered in the future?
So this is a very important question, Bob, because the randomized trials with bisphosphonates actually addressed only 1 year of randomization. And in some of the randomized trials, there was an extension period for a second year. So what the evidence tells us is what bisphosphonates are capable of doing, both in the positive and in the negative sense, during the first couple of years of treatment. Now, I have patients who have been on zoledronic acid or pamidronate for over 10 years. These are patients with metastatic breast cancer who have benefited to a large extent from this intervention. But the reality is that we do not have an organized collection of data to demonstrate either the safety or the additional benefit for chronic maintenance therapy with bisphosphonate. Now, there is one ongoing trial that is sponsored by Novartis at the specific request of the FDA, comparing monthly administration of zoledronic acid at the standard dose with every 3-month administration of zoledronic acid at the same dose after 1 year of monthly bisphosphonate therapy. Now, that randomized trial is about half accrued. It has accrued very slowly, but it will give us some additional information about whether the frequency of administration is important for the second and subsequent years of bisphosphonate therapy. Now, this is very important because the incidence of osteonecrosis of the jaw, and to some degree the incidence of renal impairment, renal function impairment with bisphosphonates, is a function of the duration of therapy and the cumulative dose of bisphosphonates administered. So in a large review we did in my institution, for instance, of about 4,000 patients treated with bisphosphonates, in the breast cancer subset of that group, after 1 year of therapy with bisphosphonates, the incidence of ONJ was less than 1%. But for patients who had received bisphosphonates intravenously every month for over 5 years, the risk of ONJ approached 7%. So it's a huge difference. And I think the question you brought up is critically important for us practicing physicians.
It seems like it's going to take a long time to collect those data when you're talking about something that's still relatively infrequent. It's 7% at 5 years.
It is going to require a long period of time, but I think we need to learn from the lessons with bisphosphonates and perhaps address these issues with denosumab and other bone-modifying agents, because it is likely that these chronic, although infrequent toxicities are probably class-related as opposed to being related to a specific drug or molecule.
Let me ask you a question about patient selection for bone-modifying agents. In the 2011 guidelines, the agents should probably only be started on patients who have some degree of bone destruction, either on plain radiographs or on CT or MRI scan. Do you have any sense in terms of patterns of care? Do you think oncologists are restricting their use of bone-modifying agents to this particular subset of patients with metastatic bone disease, or do you have a sense that perhaps there's a fair amount of use for patients just with an abnormal bone scan who are asymptomatic, have maybe a single bone metastasis or something like that?
Well, I can only comment in relation to that question on bone metastasis or patients with breast cancer, because I think in the breast cancer community, the lines between use of bisphosphonates and non-use of bisphosphonates have been blurred quite a bit. And they have been blurred because of the issue of osteoporosis and because the majority of breast cancer patients are postmenopausal. So in addition to using the drugs on label, which is to treat metastatic disease with a clear radiographic definition, I think a lot of our community, a lot of medical oncologists use bisphosphonates to treat not only abnormalities that are present only on bone scan, but also a number of patients without any bone metastases that are detectable by any form of imaging, but that have either osteoporosis or osteopenia. So a much broader range of breast cancer patients are receiving bisphosphonates because of these blurred lines. Now, something else that has contributed to this is not only the use of aromatase inhibitors that are associated, of course, with the increased risk of osteoporosis and progression of osteopenia, but also the publication of several randomized trials, some of which have suggested that the use of bisphosphonates as adjuvant therapy might reduce the risk of recurrences from breast cancer. Now, as you know, the evidence in that direction is quite mixed. And while there are some reports that suggest that this effect is indeed there are some others, including the Azure trial presented at the San Antonio Breast Cancer Symposium in 2010, that the bisphosphonates do not reduce the incidence of or the risk of recurrent or metastatic disease. Nevertheless, the cat is sort of out of the bag. And especially in higher risk patients, I think many oncologists are using bisphosphonates off-label in the hope that bisphosphonates will contribute to the efficacy of adjuvant endocrine therapy or chemotherapy. I think that's a somewhat risky proposition at this point in the absence of additional evidence, and I think the ASCO guideline committee rightfully elected not to address that issue because the data are so mixed. The bisphosphonates and more recently denosumab have really had a major impact on the management of patients with bone metastases, not only breast cancer, but other cancers. And I have seen, and so have many of my colleagues who have focused on bone disease, a marked decrease in a variety of complications related to bone metastases, such as hypercalcemia, fractures, and the disabilities associated with it. So it is quite evident that we are going to continue to use these bone-modifying agents, probably even with greater frequency, and that addressing the questions that you raised earlier during our conversation is critically important to generate the evidence so that we can use these agents safely and with optimal benefit for our patients.
Dr. Hortobagyi, thank you for taking the time to talk with me this evening.
My pleasure, Bob. Thank you for having me.
And to our podcast listeners, you can find all of the articles in the March JOP issue online at jop.ascopubs.org with full-text content available to ASCO members and subscribers, so please take a look. And let us know how we're doing with these podcasts by emailing us at jopeditorsdesk@asco.org or leaving us a comment on iTunes. We'll be back soon with another podcast for the March issue. Until then, this is Dr. Bob Miller for the American Society of Clinical Oncology. Happy spring, and thanks for listening.